Greetings, my name is Lindsay Ma, and I'm a rising intern in internal medicine. Today we'll be covering tachyarrhythmias, which is when the heart is beating too fast and abnormally. The target audience for this talk today is clerkship level medical students, so let's see what we can learn today. To start, at what level of tachycardia are we concerned? Typically, we get concerned when the heart rate is greater than 150. So let's assume nursing pages you for a heart rate of 170. You go to evaluate the patient, and what's the first thing that you want to address? Like always, we'll address ABCs. Next, we'll want to make sure they have MOV, which stand for monitor, O2, and venous access. Let's say that this patient already has two peripheral IVs, both 16 gauge, and the nurse has kindly provided 2 liters of nasal cannula, which is helping the patient saturate at 97%. The only thing outstanding is the cardiac monitor, and nursing said that they could call a colleague to grab that for you. Finally, depending on your general gestalt of the patient, you may want to call a rapid response team, which will help get some other providers at bedside, particularly ICU level nursing, who can help draw labs quickly and support in this evaluation. After you've kind of got the initial thing settled, the thing you want to assess for is hemodynamic stability, or if they're hemodynamically unstable. This includes figuring out if they have any altered mental status, hypotension, dyspnea, ischemic chest discomfort, or signs of acute heart failure. This is an important thing to evaluate for because whether there is hemodynamic instability determines whether you go down the stable versus unstable tachycardia pathway. So if there is hemodynamic instability, and we say yes, then we are going down the unstable tachycardia pathway. And that leads us straight to synchronized cardioversion. On the other hand, many of our patients may fall into this other category, where they are hemodynamically stable, warranting an answer of no, and fall into this stable tachycardia camp. Then we are following this pathway and want to figure out whether there is a narrow or wide rhythm. And how will we tell whether there's a narrow or wide rhythm? Well, it'll be important to have that cardiac monitor, as well as an EKG if possible. If it's a narrow rhythm, we can further categorize the rhythms into narrow and regular, or narrow and irregular. If you're narrow and regular, the first diagnosis you should think of is SVT. Specifically, AV-NRT in this case, and the issue is at the AV node. The reason why we want to make sure to distinguish between this and a irregular narrow rhythm is because the treatments will ultimately be different. So an irregular narrow rhythm should make you think about something like AFib or A-flutter. We can go over and identify those on our EKG strips too. Which one of these looks to be AFib? Well, it looks like this one and this one also have narrow, irregular rhythms, and the one that has the typical sawtooth pattern is considered A-flutter, whereas the other one is AFib. AFib and A-flutter can be caused by electrical impulses from several different parts of the heart, but the origin is not the AV node. As you may remember, the treatment for SVT would be first to try vagal maneuvers. If you have the time and if the patient can cooperate, vagal maneuvers including bearing down or blowing through a syringe. And then if that doesn't work, they'll most likely need IV adenosine. I like to remember this by thinking that adenosine, which has the beginning letters of AD, sounds a bit like AV, the area where it acts at the AV node. It essentially causes a pause of any signal passing through the AV node, which will hopefully treat the overstimulation of the AV node and get the patient back to a normal rhythm. That's why in the case of AFib and A-flutter, IV adenosine does not work because the origin of the irregular rhythm for AFib and aflutter is not the AV node. Instead, we'll have to use beta blockers or calcium channel blockers. Beta blockers could include metoprolol, and calcium channel blockers could include diltiazem. Now let's back up and think if this patient had a wide tachyarrhythmia, with wide tachyarrhythmias defined as a QRS wider than 0.12 milliseconds or 3 little boxes. Similarly to in the narrow rhythm case, we'll want to divide wide rhythms into two categories. The first being regular and monomorphic, meaning one appearance, versus irregular or polymorphic. Let's look at some examples of these. Over here, we have some wide complex tachyarrhythmias. The first appears to be quite regular. The oscillations that we see are regular and they look pretty uniform. This is a case of VTach, monomorphic. In contrast, the one on the bottom here looks more chaotic. Each of these waves looks different from the next, and it doesn't quite happen at regular intervals. The lengths of some of these waves are short and then long, and then some short ones and long ones and long ones. And so this would be VFib. So a regular monomorphic example would be VTach, and an irregular or polymorphic example would be VFib. The first-line treatment for VTach is the same as SVT. However, we don't actually expect the IV adenosine to help. However, this can be an important tool to help figure out if this is SVT or VT, as they can look really similar on our rhythm strips. So if you try IV adenosine and it doesn't help, then you're probably having just VT. And if it does help, then it might actually be SVT. Lastly, irregular or polymorphic tachycardias could be VFib. And in this case, we would want to treat with an IV antiarrhythmic. These medications can include amiodarone, for example, and if there seems to be a component of torsades, you would also want to include magnesium. If your first-line interventions for any of these does not get the patient back to a normal sinus rhythm, then you'll want to try IV antiarrhythmics. Evaluate for underlying causes, which you'll want to do anyway by looking at H's and T's. And then place an expert consult to cardiology. Speaking of which, what are some of the underlying causes that come to mind? A great framework to use are the H's and T's, but I've included just the 4 common underlying causes here for you to think about. The first is dehydration. Another is hypoxia, fever, and sepsis. We'll leave the H's and T's to another talk. All right, so let's summarize. If a patient's heart rate is greater than 150, we worry about a tachyarrhythmia. Once you get to the patient's room, you want to evaluate and make sure they have ABCs intact, and then ask for monitor O2 and IVs. You might want to call an RRT, and then start assessing for hemodynamic stability or instability. Specifically, evaluate their mental status, their vitals for hypotension, ask about chest discomfort or shortness of breath, and look at their fluid status. Are they giving a picture of acute heart failure? If any of these are true, then they're categorized as unstable tachycardia, and you'll want to immediately perform synchronized cardioversion. On the other hand, if they seem to be hemodynamically stable, then you go down the stable tachycardia pathway. At this point, that monitor will be really important because you'll need to look at the rhythm strip and figure out, do they have a narrow rhythm or do they have a wide rhythm? We're talking about the QRS complex. Is it greater than 3 little boxes or smaller than 3 little boxes? Let's say it's a narrow rhythm and it appears to be regular. Then we're thinking the patient might have a supraventricular tachycardia, most commonly AVNRT. Since this is an issue in and around the AV node, we can treat it with IV adenosine. And while you're waiting for the IV adenosine, you could also try some vagal maneuvers. On the other hand, you could have a narrow rhythm that's irregular, often identified as AFib or A-flutter. In both of these cases, the AV node is not the problem, so adenosine will not be helpful. However, you can start some beta blockers or calcium channel blockers. In contrast to the narrow rhythm diagnoses and treatments, we also have to consider wide rhythm diagnoses and treatments. Wide rhythms can be regular and monomorphic in the case of VT, or irregular and polymorphic in the case of VFib. When we have a regular monomorphic wide tachycardia, like VTAC, then we can try IV adenosine in case it's actually SVT. But if the IV adenosine doesn't work, we're more confident that this is VTAC and not SVT. Therefore, we'll move on to IV antiarrhythmics. If instead the rhythm is wide, fast, irregular, and polymorphic, like in the case of VFib, we'll want to jump directly to IV antiarrhythmics. And in any of these 4 cases, if those first-line medications do not seem to be improving the patient's situation by getting them back into a sinus rhythm, we'll want to employ IV antiarrhythmics such as amiodarone and evaluate for underlying causes, which should kind of be happening at any of the pause points you have during your evaluation. Those underlying causes are commonly dehydration, hypoxia, fever, and sepsis, though you can go through the H's and T's in order to more systematically cover all of the underlying causes that are commonly causing arrhythmias. Finally, consider getting an expert consult so that cardiology can weigh in and give recommendations. Your time is precious, so thanks again for joining me for this talk. Until next time.